Comparison Insight.
We are jumping right into a deep dive today. We're focusing on one of the most critical topics in cardiology, really.
Yeah, the independent predictors of adverse outcomes in heart failure.
Exactly. We've got this really comprehensive list, and our mission here is to break down how professionals are systematically forecasting risk.
And it's so important. We're looking beyond just the obvious symptoms to build a total system forecast. We're going to navigate 5 major categories:
Okay.
clinical, structural, hemodynamic, biochemical, and electrophysiologic. They all sort of interlock to give you the full picture.
Let's start with clinical and structural then. These feel like the things you can, see or get from a patient's history.
They are. And some are what you'd expect, right? Increasing age, diabetes, coronary artery disease, no surprises there.
Right. But what I found really insightful were the behavioral and more systemic indicators on the list.
Yes, things like depression and cardiac cachexia. It's fascinating because they're listed as independent risks.
And why is that? I mean, depression seems less direct.
Well, it can really affect a patient's ability to stick with treatment. And there's evidence it drives inflammation. And cachexia, that muscle wasting. That's a catastrophic sign of advanced, almost irreversible progression.
So it's not just the heart failing anymore, it's the whole body sort of giving up.
The whole body's involved.
Mhm.
And you see it in the physical exam findings, too. Simple things.
Like,
An elevated JVP, that's the jugular venous pressure you can see in the neck, or hearing a third heart sound.
which indicates what?
High filling pressure in the heart. It's a clear sign of fluid overload, which almost always tracks with an advanced NYHA class. And the list also, interestingly, includes male sex.
Okay, so moving to the structural side, this is the mechanics, right? The pump itself.
This is the pump itself. You're looking at pure mechanical inefficiency. So reduced left and right ventricular ejection fraction is the core problem. The heart just isn't squeezing enough blood out.
And that causes other problems.
It does. That inefficiency and the pressure overload that comes with it forces the heart to remodel itself, and not in a good way. You get increased ventricular volumes and mass.
The heart literally gets bigger and misshapen,
Precisely. And that stretching, that dilation, it pulls the valve structures apart.
leading to leaky valves.
Leaky valves. Secondary mitral or tricuspid regurgitation, it shows the heart's whole architecture is starting to collapse.
Okay, so if structure is the container, hemodynamics is the flow, this stuff gets pretty technical.
It can be, but it's really about measuring pump performance and congestion. The most critical metric here is probably elevated pulmonary capillary wedge pressure, or PCWP.
So what is that in simple terms?
Think of it as a measurement of the blood backing up into the lungs because the left ventricle can't handle it. It's like a traffic jam.
Got it. A high PCWP means high backup pressure. And what about the actual flow?
For flow, we look at reduced cardiac index, meaning pump output is just too low, and a really crucial one, reduced peak oxygen consumption. That tells us the absolute limit of the body's physical capacity.
Okay.
And of course, you also have things like pulmonary hypertension and diastolic dysfunction, where the heart muscle is too stiff to relax and fill properly.
Now we get to the biochemical clues. This is where the body's chemistry sends up warning flares.
Exactly. And it's not just the heart. You see these clear distress signals from other organs, especially the kidneys.
Like worsening renal function.
Yeah, that and electrolyte imbalances like hyponatremia, low sodium.
Yeah.
It shows the whole system is struggling to maintain balance. The heart and kidneys are deeply linked in failure.
And then there are the elevated biomarkers. We all know about troponin for heart muscle damage.
I do, but the really systemic warnings here come from the elevated plasma neurohormones. There are 4 key ones:
Which are?
norepinephrine, renin, aldosterone, and endothelin-1.
So with those, the body is basically hitting the chemical panic button.
That's a perfect way to describe it. It's a chronic stress response that actually helps destroy the heart over time.
Which brings us to our final category, the electrical risks. The electrophysiologic predictors. This is where things get really dangerous fast.
This is about electrical instability. It could be something as simple as a high heart rate or tachycardia, or it can be a problem with the signal's timing.
You mean like a widened QRS interval or LVDB?
Exactly. When that QRS complex widens, it means the electrical signal is traveling too slowly, which is very inefficient. Atrial fibrillation is another big one on the list.
And the most direct warnings, the most ominous signs.
That would be any evidence of electrical irritability. So ventricular ectopic activity, and of course the really scary ones, ventricular tachycardia and sudden death. Those are the immediate alarms.
Wow.